novel educational initiative by Mumbai Hematology Group and Professor Dr. M.B. Agarwal sir. Interesting topic, malignant histiocytosis, unraveling the challenges in histopathologic diagnosis. So Dr. M.B. Agarwal sir, who is a program director and also initiator of this educational initiative. So he's an institution himself and inspiration for many. We are fortunate to have him because he has enriched us by collaborating with many stalwarts across the globe, and he brought us on the virtual platform every weekend. He has been awarded the Inspiring Hematologist of India and recently Guru Dronachar Award by India Leukemia Academy. So for today's webinar, Dr. Amit Khurana sir is the moderator. He is a highly skilled and experienced hemato-oncologist with a decade of experience. He has a fellowship in bone marrow transplant, hematology, clinical hematology, and an expert himself in the hemato-oncology field. He has an extensive training in both autologous and allogeneic transplants. So without wasting any time, over to you, sir, for the further course of presentation.
Thank you so much. Let me share the screen. So very good evening to all of you, and good morning and good afternoon to all others who are joining from the rest part of the world. Today we have got three guest speakers. The first one we have is Dr. Aishwarya Ravindran from Birmingham, USA. The second guest speaker is Dana Fournier, from Executive Director of the Histiocytosis Association. And the third guest speaker is Kathy Wisniewski from the Histiocytosis Association and the Histiocyte Society. The first lecture will be on malignant histiocytosis, unraveling the challenges in histopathological diagnosis. This webinar is brought to you by Mumbai Hematology Group, supported by INTAS and managed by Perfect Square. I thank Dr. Manoj Kumar and team INTAS, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speakers for the day, Dr. Aishwarya Ravindran, Ms. Dana Fournier and Ms. Kathy Wisniewski. All our discussions were there. This is very eminent hematologist and medical oncologist, and you participants for sparing your Saturday evening, morning, or afternoon from whichever part of the world you're logged in. Tomorrow, that is Sunday, 28th of April 2024, from 11:30 a.m. Indian Standard Time onwards, we have a webinar on novel drugs in MDS by our guest speaker, Dr. Maria Diaz Campello from Spain. Let me introduce our discussions for the day. And we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. Abhishek Purohit from AIIMS Jodhpur, Dr. Akshay Mandloy from Agilus Diagnostics Mumbai, Dr. Amrit Kolar Keller from Kokilaben Hospital Mumbai, Dr. Anandraj Veti from MGMCRI Pondicherry, Dr. Anju Bharti from Banaras Hindi University Varanasi, Dr. Ankur Ahuja from AFMC Pune, Dr. Aryan Jain from PGI Chandigarh, Dr. Chitra Madivale from PD Hinduja Hospital and Medical Research Center, Mumbai, Dr. Debadita Ray from MedGenome, Bengaluru, Dr. Deepak MB from MSMC Narend Health City, Bengaluru, Dr. Gopinathan M from MGM Healthcare, Chennai, Dr. Neemya Thanda from North Okalappa General Hospital, Myanmar, Dr. Hormeas Diyar Soli Sadri from Navsari, Dr. Jyoti Sohne from Gujarat Cancer and Research Institute, Ahmedabad, Dr. Kunal Chatani from Nagpur, Dr. Kunal Goyal from Actract Mumbai, Dr. Mallikarjun Kalashetty from Manipal Hospital, Bengaluru, Dr. Manu Vimla Chandra from Colombo, Dr. Minakshi Suri from Jammu, Dr. Meenu Angi from Unipath Laboratory, Ahmedabad, Dr. Mohammad Taha Ali Khan from Hyderabad, Dr. Myat Malleswe from Medley, Myanmar, Dr. Pujita Bai Reddy from Care Hospitals, Hyderabad, Dr. Prerna Chaudhary from Jaipur, Rajasthan, Dr. Prerna Chotmal from Bombay Hospital, Mumbai, Dr. Pushpanjali Oja from Rajendra Institute of Medical Sciences, Ranchi, Dr. Ramesh Balasubramanian from Meenakshi Mission Hospital and Research Center, Madurai, Tamil Nadu, Colonel Dr. S. Venkatesan from Armed Force Medical College, Pune, Dr. Satish Kumar A. from Manipal Hospital, Bengaluru, Dr. Savitri Singh from Postgraduate Institute of Child Health, Noida, Dr. Shivani Joshi from Nasik Hematology Services, Mumbai Onco Care Center, Nasik, Dr. Subhangi Agle from Grant Medical College, Mumbai, Dr. Tushar Sehgal from AIMS, Delhi, Dr. Udyan Khachi from Dr. Udyan's Laboratory, Vadodara, Gujarat, Dr. Vidisha Mahajan from PD Hinduja Hospital, Mumbai, Dr. Yi Montan from North Okalapa General and Teaching Hospital, Yangon, Myanmar. Let me introduce our first guest speaker for the day here with us, Dr. Aishwarya Ravindran from Birmingham, USA. Dr. Aishwarya Ravindran is Assistant Professor of Pathology at Division of Laboratory Medicine, Hematopathology, Department of Pathology at the University of Alabama at Birmingham, Alabama, USA. She is a consultant hematopathologist at the University of Alabama at Birmingham, UAB, and an associate scientist in cancer control and population science at the O'Neill Comprehensive Cancer Center at UAB. She received her MBBS from Stanley Medical College in India. Subsequently, she pursued a research fellowship in hematology, followed by a residency in anatomic and clinical pathology and a fellowship in hematopathology at the Mayo Clinic in Rochester, Minnesota. While training at the Mayo Clinic, she developed a very special interest in studying rare diseases, specifically histiocytic and dendritic cell neoplasms. Her research analyzes the phenotypic and genotypic correlates in these neoplasms and integration into clinical practice. She has published numerous peer-reviewed scientific articles and was also a recipient of the Mayo Clinic Dr. Hobart K.B. Elbeck Fellowship Award and the American Society of Clinical Pathology 40 under 40 honorary for outstanding contributions to the field of pathology. She is an active member of the multidisciplinary Mayo Clinic UAB Histiocytosis Working Group, and she aims to improve awareness about these rare disorders. And today she is with us, and she is going to lecture us on malignant histiocytosis, unraveling the challenges in histopathological diagnosis. I stop over here. Over to you.
Thank you, Mumbai Hematology Group, for the opportunity to present this webinar today. I'm extremely excited to be here to share my knowledge on malignant histiocytosis, primarily with focus on histopathologic diagnosis. Diagnosing histiocytic neoplasms forms a major portion of my practice here at the University of Alabama, Birmingham. So today I'm going to integrate our research findings along with how we translate that into clinical practice in day-to-day life. So I have no disclosures. So today for the outline of the webinar, we'll start with an overview of histiocytic dendritic cell neoplasms, followed by the phenotypic characterization of this malignant histiocytosis cohort. This primarily relates to the research findings in this category of histiocytosis. And after this, thirdly, we'll get into how do we translate the research findings into clinical practice. I'll provide examples of 2 real-time cases and discuss some practical challenges we see at the scope. And finally, conclude the webinar with an approach to a histopathologic diagnosis. Talking about histiocytic dendritic cell neoplasms, so they are derived from the mononuclear phagocyte system that is comprised of monocytes, macrophages, and dendritic cells. These are all your sentinels of the immune system. In general, these disorders are very diverse and heterogeneous with over 30 subtypes. Not all of them are neoplastic entities. The term histiocyte itself could refer to tissue-resident macrophages or dendritic cells. And depending upon the extent of organ involvement, whether it is unisystemic or multisystemic, they can have variable disease outcomes as well as prognosis. In terms of the classification of the World Health Organization and International Consensus classification, there are 3 malignant histiocytosis subcategories recognized by both the WHO as well as the ICC classification of tumors, and these are highlighted in yellow: Langerhans cell sarcoma, interdigitating dendritic cell sarcoma, and histiocytic sarcoma. These 3 entities are going to be the main focus of today's presentation. However, I would also want to point out the changes in this histiocytic dendritic cell neoplasm classification in the recent classification of hematopoietic tumors. The number one being the Rosai-Dorfman disease and ALK-positive histiocytosis have been recognized as distinct histiocytic neoplasm by both these classification systems, and this is a major change from the prior World Health Organization classification in 2016. The second change is that plasmacytoid dendritic cell neoplasms, including blastic plasmacytoid dendritic cell neoplasm and mature plasmacytoid dendritic cell proliferation associated with myeloid neoplasm, is categorized in the World Health Organization under the histiocytic and dendritic cell neoplasms, whereas the ICC retains it under as a separate category of myeloid neoplasm. The third difference is that these entities, follicular dendritic cell sarcoma, fibroblastic reticular cell tumors, these actually have a different ontogeny. They arise from mesenchymal stromal cells, unlike the histiocytic dendritic cell neoplasms. So therefore, the World Health Organization has classified them under the mesenchymal stromal lesion and has removed it from the histiocytic dendritic cell neoplasm category. However, the international consensus classification retains these entities under this histiocytic dendritic cell neoplasms. Now, compare and contrast this with the Histiocyte Society classification of histiocytic disorders. This is based on the 2016 publication. This is by far the most comprehensive classification system of histiocytic and dendritic cell neoplasms, because it not only includes the neoplastic entities that is recognized by the World Health Organization and international consensus classification, but also includes the other category of histiocytic disorders, which are not necessarily neoplastic, could be just inflammatory, such as a xanthogranuloma family of lesions. In terms of this classification of these various disorders here, they classify under different buckets. These letters relate to the diseases under that category. For the purpose of today's webinar, we will be talking about malignant histiocytosis, which is classified under the M group of histiocytosis in the Histiocyte Society classification. Now, the term malignant here refers to the histologically aggressive morphology as compared to Erdheim-Chester disease, Rosay-Dorfman disease, which are also histiocytic neoplasms, could is considered to be malignant, but they're more indolent and low-grade histology on tissue biopsy. So therefore, the word malignant here is just reserved to the histologically aggressive phenomenon on tissue biopsies. Talking about malignant histiocytosis, like we discussed, these are the three subtypes recognized by both the WHO as well as the ICC classification of hematopoietic tumors. Majority are clinically aggressive as well. However, there are some isolated unifocal lesions which may show a more indolent clinical course. You know, this is one of those entities I would consider in my practice as a histiocytic emergency, because every patient that walks in the door has a different clinical course. We just don't know how these malignant histiocytosis behave in long term, and that's why we need to do more studies in terms of clinical response and prognostic outcomes per se. So in general, what we know so far is that majority of these behave clinically aggressive, as opposed to very minority of this malignant histiocytosis show a more indolent clinical course with better outcomes. In terms of the histology itself, as you can see here, they have variable degrees of nuclear pleomorphism. Some are characterized by this wreath-like nuclei. Some show binucleated binucleation. Some show some enlarged a single nucleus, and they show distinct nucleoli with abundant pale cytoplasm. Overall, this morphology is what we call as histologically aggressive or overtly pleomorphic or overtly malignant. It's just a synonymous term we use, and that puts this under the category of malignant histiocytosis. In terms of just by hematoxylin and eosin stained sections alone, we cannot distinguish these subcategories, and more so, we cannot distinguish this from the other polydifferentiated malignancies, including carcinomas, sarcomas, melanomas, and sometimes even lymphomas with anaplastic morphology, which begs the question of how do we characterize them in clinical practice by immunohistochemistry, which is the most available, the best tool to subclassify these tumors. Hence, that is going to be the focus of today's presentation. In order to understand the phenotypic spectrum of this malignant histiocytosis, as well as the other more indolent histiocytic and dendritic cell neoplasm, it is essential to understand the ontogeny of the mononuclear phagocyte system. Prior to birth, the embryonic cells, which is the yolk sac and the fetal liver, are the site of hematopoiesis. But at the time of birth, the bone marrow takes over, gives rise to the hematopoietic stem cells. Hematopoietic stem cell, in turn, gives rise to the monocyte dendritic cell progenitors, as well as the common dendritic cell precursors, which then differentiate into monocytes and dendritic cells. And in times of inflammation or some infection, these monocytes and dendritic cells get recruited to the tissue sites and differentiate into macrophages and dendritic cells. Now, these areas that are derived from the bone marrow, they are your recruited macrophages and dendritic cells. There is another category called as the resident macrophages. This is one of the fascinating physiology, is that these resident macrophages that are derived from the embryonic precursors are completely independent of the bone marrow throughout adult life in an otherwise homeostatic environment. And these include your microglial cells in the brain, your epidermal Langerhans cells, Kupffer cells in the liver, osteoclast, alveolar macrophages, and so forth. Both resident macrophages and recruited macrophages contribute to tumor growth. In talking about the neoplastic counterparts, when there is a trigger, typically a genetic hit, an acquired somatic mutation in these cells, these give rise to the histiocyte macrophage neoplasm if it's a hit in the macrophage cell of origin, or dendritic cell neoplasm if they arise from the monocyte dendritic cell lineage or the classic dendritic cell lineage. There are other neoplastic entities too, such as plasmacytoid dendritic cell neoplasms, which includes the blastic plasmacytoid dendritic cell neoplasm. These arise from the PDCs, and the acute monocytic leukemia, which is a myeloid neoplasm arising from the monocyte. For the purpose of today's presentation, we will be talking about the histiocyte macrophage and the dendritic cell lineage. In terms of the genetic hit, the most commonly involved pathway in histiocytic dendritic cell neoplasms, as proven by literature over the past decade, is the MAP kinase pathway activation. The most common genetic mutation in the MAPK pathway involves the BRAF gene, and this is present in about 50 to 60% of Erdheim-Chester disease, Langerhans cell histiocytosis, as well as a subset of malignant histiocytosis. And in the other pathways that is involved is this PI3-AKT pathway that's also present in approximately less than 1/3 of these histiocytic dendritic cell neoplasms. There is a stain called phosphorylated ERK. This is an immunohistochemical marker, as well as a phosphorylated AKT. This is also an immunohistochemical marker. In my practice, we routinely use this to figure out which pathway is more active even before the NGS comes out. Now, this immunohistochemistry in isolation is not very definitive, but it helps along with the other immunohistochemical panel to figure out if this is a histiocytic neoplasm with associated MAP kinase pathway activation or PI3K activation. This is a bird's eye overview of this malignant histiocytosis classification in the Histiocyte Society. Now, these malignant histiocytosis can be primary, which is de novo, or secondary, typically arising in association with a hematolymphoid malignancy, most commonly a lymphoma. And these primary and secondary could be either of these subtypes. Now, majority of the subtypes, 3 out of 4, is recognized by the WHO and ICC classification. But there is a fourth category called as the indeterminate cell sarcoma, which is only recognized as a distinct entity by the Histiocyte Society classification. Now, essentially, the malignant histiocytosis is an umbrella term for all of these categories. So how we subtype it, it's going to rely heavily on immunohistochemistry. Now, coming to the next section of this talk is a characterization of the phenotypic spectrum. Now, this section is primarily going to be based on this research article we published from our group a few months ago. The primary aim of this research study was how can we expand on the phenotypic spectrum of malignant histiocytosis, given that there are multiple different subtypes here, at least 4 that is known to us, and how we can use those immunohistochemistry panel to designate a histiocytic dendritic cell lineage and differentiate them from other more polydifferentiated malignancies. The second part of this paper was to provide some insights into how these malignant histiocytes parallel the spectrum of their normal immune counterparts, such as monocytes, dendritic cells, Langerhans cells, as well as macrophages. So in this cohort, we included about 22 cases, and it's over a 20-year-old period. We only chose those cases which had adequate formalin-fixed paraffin-embedded tissue available. There were more than 22 cases that was diagnosed over the 20-year period, but only 22 cases had enough material for us to perform extensive ancillary studies. The immunohistochemistry panel were primarily chosen based on the category and lineage of these histiocytic and dendritic cell markers. Monocyte macrophage markers include the CD68, CD163, CD14, factor 13A. OCT2 is a B cell transcription factor. Many of you would know that we use that to distinguish nodular lymphocyte predominant Hodgkin lymphoma from classic Hodgkin lymphoma. But OCT2 also is a monocyte macrophage marker. We recently have published our research findings on OCT2 being expressed in Rosé-Dorfman cell histiocytes, but it's negative in reactive histiocytic proliferations. So that was the rationale to use OCT2 in this paper. In next set of markers with the Langerhans and dendritic cell markers, they include the CD1A and Langerin, and that's known to everyone, as well as S100, CD11C, and lysozyme. Now, ZBTB46, I want to place special emphasis on this marker. This is a really very useful practical marker in day-to-day practice because this is a sensitive and a specific dendritic cell marker. It marks only the dendritic cells and is negative in the monocytes and macrophages. The other markers we used were cyclin D1 is a cell cycle marker. It also gets upregulated when it's downstream of MAP kinase pathway activation. And beta V600D, given that beta V600D is the most common mutation in majority of histiocytic and dendritic cell neoplasms. We chose an arbitrary cutoff of 30% just because we didn't want to overcall the immunohistochemistry as positive. So unless otherwise noted, all of these markers were scored as positive if it was present in at least 30% of the tumor cells. In terms of the results, majority were males with malignant histiocytosis with a median age of 64 years. Now, depending upon the different categories of the immunophenotypic markers I just showed, we divided these 22 cases into 5 different phenotypic lineages, and we'll be discussing each of the lineages and what each one entails and how this compares to the more indolent, low-grade appearing histiocytic dendritic cell neoplasms. So talking about the macrophage lineage, there are about 5 cases. Interestingly, all of them had an extranodal site of involvement. The key phenotypic markers that characterize the macrophage lineage are CD68, which is positive in all of these histiocytic dendritic cell neoplasm, regardless of this category or subtype of histiocytic neoplasm. The other markers that characterize the macrophage lineage include CD163, CD14, factor 13A. The key takeaway from this lineage is that it's negative for OCT2. OCT2 is a monocyte macrophage marker, and S100 was negative in a majority of these cases, and as well as dendritic and Langerhans cell markers, which are the ZBTB46, CD1A, and Langerin, uniformly negative in all of these 5 cases of macrophage phenotype. So this macrophage phenotype, this is an example of a case which would be subclassified as histiocytic sarcoma per the WHO as well as the ICC classification. And this phenotype shows this lesional cells being positive for CD68, CD163, diffuse positivity for cyclin D1, CD14, and factor 13A, and negative for S100 and OCT2, as well as the dendritic and Langerhans cell markers. This macrophage phenotype is similar to its indolent low-grade appearing counterpart. This is a case of Erdheim-Chester disease, which also demonstrates a similar phenotypic expression just like the malignant histiocytosis with macrophage phenotype, where these foamy histiocytes are characterized by CD163, cyclin D1 expression, factor 13A. Majority of ECD are typically S100 negative. If it's positive, then it's usually only a minor subset of this tumor cells showing S100 expression. This is a case of BRAF V600D mutated ECD, and this immunostain is very sensitive and specific and acts as a surrogate for the BRAF V600E mutation. In terms of histology itself, this is a very bland appearing histology. It's characterized by this bland nuclear features, abundant foamy cytoplasm, in contrast to the malignant histiocytosis, which showed more a pleomorphic morphology. Now, switching gears to the next phenotypic lineage, this is a monocyte macrophage lineage. These also comprised about 5 cases, variable sites of involvement, including nodal as well as extranodal sites. It shows similar phenotypic features to the macrophage lineage, the key difference being it also showed uniform positivity for both S100 as well as OCT2. Now, similar to the macrophage lineage, it was negative for dendritic and Langerhans cell markers. The key phenotype of this monocyte macrophage lineage is this S100 and OCT2 expression. And this is an example that depicts this malignant histiocytic cells, which in addition to being positive for all these macrophage markers, were also positive for S100 and OCT2. In general, given this diffuse S100 expression, in terms of the counterpart of subclassification in World Health Organization as well as international consensus classification, this category would be classified under interdigitating dendritic cell sarcoma. And in terms of the S100 expression, it reminds of Rosay-Dorfman disease phenotype, which is characterized by S100 as well as OCT2 positivity. And interestingly, all of these 5 cases of monocyte macrophage phenotype also showed emperipolesis, which is the engulfment of these inflammatory cells. These pockets here in this malignant histiocytic nuclei are your inflammatory cells, which are typically lymphocytes, plasma cells, and sometimes neutrophils too. Emperipolesis, I want to make a note that it's not pathognomic for any histiocytic neoplasm. It's just that it's a finding that is more frequently observed in Rosay-Dorfman disease as well as Rosay-Dorfman disease like phenotype of malignant histiocytosis. Comparing this morphology to a classic case of Rosay-Dorfman disease, this monocyte macrophage phenotype of malignant histiocytosis parallels the same phenotypic spectrum of Rosay-Dorfman disease. These cells here, these are Rosay-Dorfman cells characterized by essentially a round to oval nuclei, and majority of the cells essentially have the same nuclear size and shape as compared to the malignant histiocytosis, which is more exhibits variable degree of pleomorphism. Now, this shows emperipolesis here, which is the engulfment of lymphocytes, neutrophils, and also some plasma cells. This Rosay-Dorfman disease is positive for CD163, cyclin D1, variable degree of factor 13A expression, and is uniformly positive for S100 and OCT2, similar to our monocyte macrophage phenotype of malignant histiocytosis. One thing I want to mention for a practical purpose is that CD163 can be negative in approximately 10 to 15% of Rosay-Dorfman disease. So a negative CD163 shouldn't lead us away from a diagnosis of a histiocytic neoplasm. Now, switching gears to the third phenotypic subcategory is this dendritic cell lineage. Now, this is characterized by positive expression of dendritic cell marker, which is CBTB46. There were variable expression of CD1A and Langerhans, but it was less than 10% of the tumor cells in majority of these cases. Some of them had less than 5% expression of CD1A and Langerhans, or either CD1A or Langerhans. Only one case here had CD1A expression in greater than 30% of the tumor cells, but since it was Langerhans negative, and that is the reason this was classified under the dendritic cell lineage and not under Langerhans cell lineage. In terms of the phenotype itself, this has a really peculiar pattern of staining with CD68 and lysozyme, which is the Golgi dot-like positivity. If you observe this pattern at a low power objective, we will certainly miss this as positive staining. So we need to go at 40x objective to identify these cells that show this dot-like expression in this category. This was negative for your macrophage phenotype markers such as CD163, CD14, and factor 13A had variable expression of OCT2. Now, this is an example of a dendritic cell lineage where these malignant cells show positivity for CD68 and lysozyme. And as you can see here, this is a really subtle dot-like Golgi staining that's shown in these dendritic cells here. And this is what can be missed at a 10x objective or 4x objective. So we really need to go at a 40x objective to observe this pattern of staining. Dendritic cells are typically CD163 negative, and that's another thing to take away is that CD163 is technically a more sensitive and specific histiocytic lineage marker, but its negativity doesn't rule out a histiocytic dendritic cell neoplasm, which is why we always need to do a panel of histiocytic and dendritic cell markers for excluding or evaluating for a histiocytic dendritic cell neoplasm. Now, this was positive for 11C. 11C is more uniformly positive in dendritic cell lineage as opposed to the macrophage and monocyte macrophage lineage. Similar to the other subcategories, this was also diffuse cyclin D1 positive and showed diffuse S100 expression, positive for ZBTB46, negative for CD1A and Langerin in this particular case. In terms of the parallel classification in the WHO and ICC classification of hematopoietic malignancies, this would be categorized as interdigitating dendritic cell sarcoma. But in my practice, when I have a case of malignant histiocytosis, I typically just call it with an umbrella term, malignant histiocytosis, consistent with the subtype of interdigitating dendritic cell sarcoma. So it's just a preference of how you sign out reports. It's not essentially necessary for you to specifically put it into a bucket category if you're not able to, but the key takeaway is that these are malignant histiocytosis. And this is another category or another case under the dendritic cell lineage, which showed an indeterminate cell phenotype. And this is a category that is recognized only by the Histiocyte Society classification, not by the WHO and ICC classification. This is characterized by these overtly pleomorphic appearing cells that is positive for CD1A but negative for Langerin. This is what defines the indeterminate cell phenotype. Now, this category was also positive for beta V600, which can occur in a subset of malignant histiocytosis. And the other markers included cyclin D1 being diffusely positive, just like any other malignant histiocytosis. CD11C, it's typically positive in a dendritic cell phenotype of histiocytic and dendritic cell neoplasms. S100 shows diffuse positivity here, and OCT2 is also diffuse positive. Now, one can ask if S100 is diffusely positive, why this is not interdigitating dendritic cell sarcoma. It is not interdigitating dendritic cell sarcoma because it has CD1A expression and Langerin negativity, so it's better classified under the indeterminate cell category. And along that lines, this is the distinction between indeterminate cell sarcoma and interdigitating dendritic cell sarcoma. That could be a lot of overlap in semantics, leading to confusion amongst us for classification purposes. But again, the key takeaway is these are malignant histiocytosis. If you're not able to classify, it's always okay to put in a comment about what are the immunophenotypic features that you think that puts it under the category of malignant histiocytosis and not under the category of any other poorly differentiated malignant neoplasm. Now, this is again a case of indeterminate cell sarcoma, CD1A positive, Langerin negative, BRAF V600 positive. The interdigitating dendritic cell sarcoma can have overlap between a monocyte macrophage as well as a dendritic cell phenotype. Now, this is in general has consistent S100 diffuse positivity, negative for the dendritic cell markers such as CD1A and Langerin. Now, switching gears to the last phenotypic subcategory here is a Langerhans cell lineage. By definition, regardless of what other markers they express, these are positive for CD1A and Langerin, and they typically positive for the other markers, including CD68, CD11C, ZBTB46. See, unlike the pure dendritic cell lineage, these show more uniform expression of CD163 as compared to the DC lineage being like completely negative for CD163. That's because the Langerhans cell lineage often overlaps with macrophage phenotype or overlaps with monocyte macrophage phenotype. Hence, that could be overlap with expression of other immunophenotypic markers. But again, the key key takeaway here is only the uniform positivity for both CD1A and Langerin. Variable expression of OCT2, S100, and lysozyme was seen in this category of cases. Now, this is a case of Langerhans cell sarcoma where these malignant histiocytes are positive for CD163, cyclin D1, ZBTB46, S100. As you can see here, it was positive for both CD1A as well as Langerin. This was a case of BRAF V600D mutated Langerhans cell sarcoma. BRAF V600D mutation was predominantly or more commonly observed in the dendritic cell and Langerhans cell lineage in the cohort of malignant histiocytosis, at least in our study. So the dendritic cell and Langerhans cell phenotype, now they are parallel counterparts of low-grade histiocytic neoplasm would include the Langerhans cell histiocytosis, which is characterized by this essentially elongated, bland-appearing nuclear features with nuclear grooves, also known as coffee bean nuclei, and they are positive for both CD1A and Langerin. And there's another category of indeterminate cell histiocytosis. Now, this category is also known by the terminology called indeterminate dendritic cell tumor in the WHO and ICC classification is essentially the same as indeterminate cell histiocytosis. This, similar to Langerhans cell histiocytosis, also has the same low-grade appearing histology, with the exception being at the phenotypic level, it expresses CD1A, but it's negative for Langerin. In terms of CD1633, in general, I've seen a majority of Langerhans cell histiocytosis and indeterminate cell histiocytosis being negative for CD163. A minority of these cases may demonstrate positivity for CD163. Typically, that's something that we need to be aware of because what you're assessing here is the tumor cells. There might be admixed background reactive histiocytes that show CD163 expression. So we should exercise caution while we evaluate this positivity, whether it's present on the tumor cells of interest or whether it's present in the background admixed reactive histiocytes. Coming to the primary versus secondary malignant histiocytosis, in our study of 22 cases, majority were de novo cases with a median overall survival of 41 months approximately. But there is a minority of cases, about 8 cases, which were secondary malignant histiocytosis. And interestingly, all of them were arising in the setting of transdifferentiation from a prior B-cell lymphoma. I use the word transdifferentiation as a better synonym to secondary malignant histiocytosis because it demonstrates a lineage switch, which means a lymphoid lineage changing its lineage subtype to a histiocytic dendritic cell lineage. So that's what the word transdifferentiation entails and not transformation, which is essentially the same lineage that goes from a low-grade histology to a high-grade histology. Here, the median overall survival of secondary malignant histiocytosis was 5.2 months. It is much shorter than the median overall survival of a primary malignant histiocytosis, but I deliberately did not reveal the statistic analysis because it's still a low number of patients to reliably conclude anything significant thus far. So we need to follow these cases prospectively to see how they do in terms of treatment response and prognosis. And that is one of the reasons I said every malignant histiocytosis is going to be different, and each case is going to have different response to therapies and as well as prognosis. And this is a summary of our secondary malignant histiocytosis in our cohort of cases. It's interesting that majority were dendritic and Langerhans cell phenotype, approximately 50% of our cohort of the secondary malignant histiocytosis. None of the 5 cases with macrophage phenotype were secondary malignant histiocytosis. All of them fell into the category of primary or de novo malignant histiocytosis. In terms of confirming the shared clonality, we did either FISH or B-cell immunoglobulin gene arrangement or next generation sequencing, both in the tissue involved by lymphoma as well as in the tissue involved by malignant histiocytosis, and confirm the shared clonality between the lymphoid and the histiocytic component prior to delivering the diagnosis of secondary malignant histiocytosis. The median time to transdifferentiation was variable, is about 62 months with a range of 2.4 to all the way to 181 months. This is a mutational landscape of malignant histiocytosis. About 18 of 22 cases had NGS performed either as part of their clinical care or as part of this research cohort where we did whole exome sequencing. And in terms of the findings, just like has been established in the literature, majority harbored the MAP kinase pathway mutation, about 80% of the cases. The 29% of these cases harbored the PI3K AKT pathway mutations. There were also epigenetic mutations found in about two-thirds of the cases, and that is something. Epigenetic mutations like TET2, DNMT3 are your common CHIP mutations. These histiocytic dendritic cell neoplasm can be associated with myeloid neoplasms, so it was which also were confirmed by the finding of epigenetic mutations in this category. As I mentioned before, the BRAF mutations were more common in the dendritic and Langerhans cell phenotypes. In addition to this NGS profile, we also compared this with another panel of immunohistochemistry markers. Now, these were not used for phenotypic purposes itself. These were utilized to understand more of the underlying molecular signatures. Cyclin D1, as you can see, is uniformly positive across all the malignant histiocytosis. P16 here was very much variable between the different cohorts, doesn't necessarily correlate with any significant clinical data points. The reason or rationale behind using P16 is that P16 expression has been correlated with multifocal disease in patients with Langerhans cell histiocytosis. So, but however, in our cohort of malignant histiocytosis, we did not find any significant relation between P16 expression and multifocality. P53, interestingly, P53 is very well established in myeloid malignancies, where a P53 positivity in the myeloid neoplasms correlate with P53 mutations. However, we did not observe that in histiocytic and dendritic cell neoplasm. There was only one case that correlated with TP53 mutation, where the mutation was present and the IHE showed a very strong expression. However, those without TP53 mutation were also showing variable degrees of P53 expression by immunohistochemistry. Now, coming to the last two markers were the phosphorylated ERK and phosphorylated AKT. As I mentioned, we use that to identify if they are if there is a MAP kinase pathway activation wherein PERK will be strongly expressed. This is a PI3 AKT pathway activation, whereas PAKT will be strongly expressed. We found the variable degree of expression in different cases here. The only time PERK and PAKT will be helpful, at least in my experience and opinion, is that PERK, if it's positive, say it shows strong 3+ positivity, and say PAKT is completely negative, then it probably helps us to know that there is only MAP kinase pathway activation. But or the vice versa. If PAKT is positive and PERK is negative, then you can suggest that, oh, there's possibly PI3K AKT pathway activation. But if both the markers are positive, then it's really, we have to defer to NGS. So it's really not very correlative in terms of what pathway is active when both the IHC markers are expressed. But when one is expressed and the other one is negative, then it might be helpful to suggest which pathway is more active even before the NGS results come back. Now, a summary of these findings is that based on what we have seen, we know that these exist in a spectrum and are very heterogeneous, and we need a panel of immunostains to characterize them or even classify them as malignant histiocytosis and differentiate from your other poorly differentiated neoplasms such as carcinoma, sarcoma, melanomas. And right now, we don't know whether there's lineage subtypes, including the macrophage, MOMAC, DCLC, or the parallel subclassification categories in the WHO and ICC, which is histiocytic sarcoma, indeterminate cell sarcoma, interdigitating dendritic cell sarcoma, Langerhans cell sarcoma. We don't know whether there exists a difference between the subcategories. So that is something we need to just prospectively evaluate as we try to learn more about these rare diseases. In terms of this classification of this malignant histiocytosis, this is a bird's eye overview of how a phenotypic characterization correlate with this recognized subcategory of malignant histiocytosis by the Histiocyte Society classification. Macrophage phenotype essentially will be subclassified under histiocytic sarcoma. Monocyte macrophage phenotype could be either histiocytic sarcoma or interdigitating dendritic cell sarcoma. If it is consistently S100 positive and negative for dendritic cell markers, then it's best classified under IDCS and not HS. Dendritic cell phenotypes can be overlapping between IDCS, indeterminate cell sarcoma, as well as Langerhans cell sarcoma. the immunophenotypic markers will give us a clue as to which subcategory we can put this into per the Histiocyte Society classification. Langerhans cell phenotype, on the other hand, is always classified by positivity for both CD1A and Langerhans immunostains. Now, how do we translate these research findings into clinical practice? I'm going to be presenting two cases. So case number one, this is a 61-year-old man with a history of chronic lymphocytic leukemia and small lymphocytic lymphoma. He was diagnosed 8 years ago. He had chemotherapy back then, was doing extremely well with complete response. He presents to the emergency department with abdominal pain, and imaging was done, which showed a perforated bowel. He was taken into surgery for a right hemicolectomy, which showed diffuse large B-cell lymphoma germinal center phenotype. He underwent 6 cycles of R-CHOP, complete response, clinically and by radiologic studies. 5 months post-treatment, however, he presents with increasing abdominal discomfort, and imaging showed a 4.2 centimeter mesenteric mass with multiple associated sites of lymphadenopathy. Now, at this point, clinically and even as a pathologist looking at the history, the first thing that comes to mind, this is more than likely a 95% probability that this is going to be a recurrent diffuse large B-cell lymphoma. So fine needle aspiration was done, which showed this somewhat discohesive cells, but they're really large. They have multiple nucleoli and abundant cytoplasm. In the context of the known history, this was positive for malignancy, called out as favor recurrent lymphoma. However, the next day, the core biopsy was performed, and the core biopsy showed this kind of variable degree of pleomorphism in the cells of interest. Some of them show vacuolated cytoplasm, some of them showed abundant pale eosinophilic cytoplasm. Clearly, at a first impression, it didn't look like a lymphoid process here. It looked something more aggressive than a lymphoid. However, given the known history, B cell markers were performed. CD20 is negative, which could be attributable to the post-rituximab effect, because sometimes they can show variable time periods before which they can express CD20 even after rituximab is stopped. The other B cell markers, however, should not be negative in a case which is only treated with rituximab. So PAX5, CD19, and CD79A being negative would be extremely unusual for a mature B cell lymphoma post-treatment. So therefore, this begs the question, what this tumor could be. So going back to the morphology, revisiting it again, this point in time, my suspicion, well, I have a special interest in histiocytosis, but also on the flip side is that I shouldn't be overcalling tumors as malignant histiocytosis. That was my extra caution that I had to take in this case. However, this case really bugged me that this is likely, more than likely, going to be malignant histiocytosis, given the history of lymphoma, and lymphomas can transdifferentiate to histiocytic neoplasm of post-treatment. So did a CD1633 marker, and it was diffusely positive, confirming my suspicion that this is indeed a malignant histiocytosis. For further phenotypic characterization, did the additional immunophenotypic markers, and this is where my research findings comes into translating into a true clinical histopathologic diagnosis, wherein these CD163 positive cells are positive for CD14, partially positive for CD11C, cyclin D1, diffusely positive for S100 and OCT2. Now, this is again a Rosai-Dorfman disease-like phenotype, and this diffuse S100 positivity is what would classify under the category of interdigitating dendritic cell sarcoma per the WHO and ICC classification of hematopoietic tumors. But like I said, in my reports, I always call this malignant histiocytosis, subtype interdigitating dendritic cell sarcoma. In our practice, we do NGS in all of our histiocytic cases. And for malignant histiocytosis, the priority is triaging tissue for next generation sequencing. This is extremely important in all the cases of suspected malignant histiocytosis. So we'll be able to identify the mutations which can be utilized for targeted therapies. This case had a bona fide KRAS mutation. This is part of the MAP kinase pathway, had a gain of function mutation with a variant allele frequency of 12.1%. This is likely the driver in this case, as majority of the other genes, including the BRAF, but this was in the non-V600E coding region. They were all loss of functions here. So the driver in this case was KRAS pathogenic mutation. So given the history of lymphoma, now we need to demonstrate that shared clonality with the prior B-cell lymphomas. So we did B-cell gene arrangements in the DLBCL component and the malignant histiocytosis component. And as you can see here, there are shared clonal peaks in both of them, confirming the suspicion that it's the same clone, and this was arising in the setting of transdifferentiation. Unfortunately, CLL was inadequate sample, so we couldn't pursue B-cell gene arrangements. So the final diagnosis in this case was malignant histiocytosis subtype IDCS resulting from transdifferentiation of prior B-cell lymphoma. In terms of the summary of genetic abnormalities, CLL, back 8 years ago, the patient had cytogenetics performed and showed a trisomy 12. Interestingly, the same trisomy 12 clone was present in DLBCL as well as malignant histiocytosis. And the KRAS mutation found in malignant histiocytosis was also found in the DLBCL. So it's interesting how this common clonality led to the process from a low-grade lymphoma to an aggressive large B-cell lymphoma, where there was a transformation which took about 8 years and a transdifferentiation that took about 5 months. Follow-up this case, ICE chemotherapy was contemplated. Unfortunately, the patient did not survive. This is one of the example cases that emphasizes that every malignant histiocytosis, in my opinion, should be treated like a histiocytic emergencies, because we just don't know how each patient would respond to therapy in terms of, or at least like be able to receive the therapy or wait for the NGS results for targeted therapy and so forth. So hence each case should be evaluated as a whole, and with priority being next generation sequencing studies. Case number 2, this is an 11-year-old with a history of T lymphoblastic leukemia. He was diagnosed over a year ago, had minimal measurable residual disease analysis negative in the first month post chemotherapy. He was doing well apparently for a year, and 15 months later presented with some systemic symptoms, and also a CT showed an aggressive mass in the nasal sinus, which was biopsied, and that was composed of the sheets of this overtly malignant cells with this multinucleated wreath-like nuclei, abundant cytoplasm, giving an appearance of a distinct malignancy. More than likely, this is going to be histiocytic lineage because the patient has a history of a hematolymphoid, which is T lymphoblastic leukemia. And commonly in kids with T lymphoblastic leukemia, when they present, or B lymphoblastic leukemia, when they present with this aggressive morphology, more than likely, majority of the times, they are transdifferentiated histiocytosis. So this panel of immunohistochemical markers were performed, positive for CD68, CD163, cyclin D1. S100 was not diffusely positive here, but OCT2 was positive, showing in this cells with this large cells. OCT2 can also be positive in the small B cells and plasma cells in the background. So we need to exercise caution in evaluating OCT2 in the neoplastic cells of interest when there are abundant admixed reactive B cells and plasma cells. A PDL1 it was done on this case. Now, I do PDL1 in all my malignant histiocytosis cases because we just don't know exactly what is the protocol to treat these cases. So if PDL1 is positive, it really helps in targeting with immune checkpoint inhibitors. In terms of scoring of PDL1, there isn't an established algorithm in hematolymphoid malignancies when compared to the other solid tumors. In general, the scoring is positive when the tumor cells show membranous positivity of the PDL1 clone. I prefer to use the 22C3, which is an FDA-approved clone, but there are also other clones which can be utilized. So this was a case of histiocytic sarcoma because of the phenotype here, and would be under the umbrella of malignant histiocytosis. Now, given the history of T lymphoblastic leukemia lymphoma, the bone marrow was done as well as part of staging studies to see if the bone marrow showed any residual TLL. MRD was negative for T lymphoblastic leukemia. However, the bone marrow showed involvement by histiocytic sarcoma with similar immunophenotype to the nasal mass. Given the history of TALL, a T cell gene arrangement was done in this case, and it was positive in this malignant histiocytosis, which favors the transdifferentiated malignant histiocytosis. NGS was performed, which showed some multiple mutation. Interestingly, a fusion. I've not observed this in our cohort of malignant histiocytosis that we evaluated for our research study. This fusion is being found in other solid tumors, but essentially results in downstream MAP kinase pathway signaling. I also did a PERK here, and PERK here shows strong nuclear and cytoplasmic staining in the malignant histiocytes of interest, and also suggesting activation of the MAP kinase pathway. PERK can also stain fibroblast, endothelial cells, and so forth. So essentially, we need to be careful about evaluation of PERK. We need to make sure these are the malignant histiocytes of interest and not just any admixed reactive macrophages or fibroblast or other endothelial cells in the background. So in terms of follow-up, the patient was initiated on cobimetinib, which is a MEK inhibitor. Given the MAP kinase pathway activation, it is left to see how the patient performs in long term. So now, practical challenges of the scope. I want to discuss two case scenarios briefly. Now, this is a patient who had a large soft tissue mass infiltrating the bone, who comes to the clinic, and when biopsy was done, showed this spindle to epithelioid appearing cells with abundant cytoplasm. It's no doubt this is a malignant neoplasm, but in terms of categorization, all markers, including melanoma markers, skeletal markers, carcinoma markers, including multiple types of keratins, and hematolymphoid markers, that is CD45, CD43, were negative. No sarcoma gene fusions were identified. CD68 and CD163 was performed and initially called as histiocytic sarcoma. Now, I want to also point out that CD45, CD43 can be variable in malignant histiocytosis, typically dim to weak, but sometimes they can be negative as well, in which the tumors will completely lose expression of CD45 and CD43. So negativity doesn't rule out a histiocytic lineage. However, this patient went into the hematology clinic, and the hematologist triggered a second opinion by hematopathology because previously it was not seen in hematopathology. So when I see this morphology, yes, it is a malignant neoplasm, but however, we need to evaluate the immunohistochemistry. On reviewing the slides of CD68 and CD163 at higher power, your malignant cells are negative for the CD68 and CD163. So what was showing as positivity is your admixed reactive histiocytes. So this was a case of an undifferentiated pleomorphic sarcoma and not malignant histiocytosis. So take-home points from this case is important to evaluate these neoplasms with at least two histiocytic lineage or two dendritic cell lineage markers. And we need to ensure these cells are expressed only in the malignant histiocytes of interest and not in your admixed reactive histiocytes, because a lot of tumors, including soft tissue sarcomas, melanomas, carcinomas, can show histiocyte-rich background. Even lymphomas do that too. So it's important to make sure what we're evaluating is our cells of interest. PU.1 is a really good marker. I'll show you an image towards the latter part of this talk. It's a nuclear marker, and it crisply highlights the cells of interest as opposed to the CD68, 163, and CD4 being a more membranous and cytoplasmic staining, which could cause confusion with admixed reactive histiocytes. And admixed histiocytes can also show reactive atypia, and a panel of immunostains is key to distinguishing this reactive from malignant histiocytosis. And it's important to consult our colleagues and show these cases and work as a team between hematopathology and soft tissue pathology so we can accurately subclassify these malignancies, especially in those soft tissue sarcoma mimics that have histiocyte-rich background. Now, scenario number 2, this is a patient with a history of AML with monocytic differentiation, was status post induction chemotherapy. This is a day 14 bone marrow. I get the right GIMSA stained cytospin for which was performed as a part of a flow cytometry analysis, and I see these overtly histiocytoid appearing cells with this prominent nucleoli, but some of them even had multinucleation. This didn't appear to me like with blast morphology. And when you compare with a core biopsy, certainly they have this kind of cytoplasm, a mild degree of nuclear irregularity, doesn't upfront look like acute myeloid leukemia. So there was some concern going around this morphology, and going at a higher power view of the bone marrow core biopsy, you can see the cells being like prominent nucleoli, enlarged nucleus, some moderate to abundant cytoplasm. Compare this morphology to the diagnostic bone marrow, which was involved by AML, where they show relatively a monomorphism morphology with this round nuclei with fine chromatin, distinct nucleoli, as opposed to this one showing a slightly more malignant appearing morphology. Now, compare and contrast this bone marrow aspirate smears. Now, these are not megakaryocytes. I can assure that there were no megakaryocytes in the bone marrow core biopsy, and these nuclear features don't support a megakaryocytic cell type. So these are your cells of concern, which means the histiocytoid cells, which we saw on the right Giemsa stained cytospin. They show this multinucleation, prominent nucleoli, and compare and contrast this with your diagnostic bone marrow, which showed a really monomorphous population of this mononuclear cells, which are the blast, including promonocytes, monoblast, and myeloblast. And the question right now is that, is this malignant histiocytosis? So coming to the immunophenotypic characterization, I did CD68, myeloperoxidase. A subset of the tumor cells were positive for CD163, and all the cells were uniformly negative for cyclin D1, which would be very unusual for malignant histiocytosis because they typically show cyclin D1 positivity. Now, the CD68 positive and myeloperoxidase positive would put this into a category of a myelomonocytic phenotype. TP53 immunostain was done and showed uniform strong positivity in these tumor cells of interest. NGS also showed a TP53 gene mutations, which was also present at the time of initial diagnosis. And this is a case of bizarre nuclear atypia in the context of post-chemotherapy effect on TP53 mutant cells. This is a well-known phenomenon that you typically see in the setting of pure erythroid leukemia. But it also, we need to be aware that this TP53 mutation in other subtypes of myeloneoplasm can also exhibit varying degree of nuclear atypia, which can sometimes confuse with the diagnosis of malignant histiocytosis. Final diagnosis in this case was persistent acute myeloid leukemia. Comparing to the initial diagnostic bone marrow, it showed similar immunophenotype to what we had in the day 14 bone marrow, with the exception being CD163 was predominantly negative, but it was positive in a subset in day 14 bone marrow. Those are your bizarre histiocytoid appearing cells, which were atypical cells in TP53 that are TP53 mutated. That are atypical and histiocytoid appearing because of post chemotherapy. Now here again, cyclin D1 was diffusely negative as well. So similar immunophenotype to what the day 14 showed. So take-home points from this: correlating with history, morphology, immunophenotype, and genetics is key to distinguishing the immature from the mature phenotype, that is blast from your malignant histiocytes. TP53 mutated AML cases can exhibit and demonstrate variable degree of cytologic atypia, in fact, variable degree of nuclear pleomorphism, and that's something we need to factor in when we're evaluating this TP53 mutated cases post-therapy. Finally, the last section of this webinar, concluding with an approach to histiocytic neoplasm. Now, this is a PU.1 immunostain. As I told you before, I prefer this marker compared to CD68 and 163, but I always do this in conjunction with other histiocytic markers, as it sharply delineates this malignant histiocytes here. But remember, PU.1 also marks background B cells, neutrophils, and as well as reactive macrophages. So what we are really evaluating is the cells of interest in conjunction with other immunostains. So whenever there is histiocytic infiltrates, if it's mass forming, if there is a clinical, pathological, or radiologic suspicion, my recommendation is to get it evaluated by a hematopathologist. And this is my recommended immunohistochemistry panel of at least doing 2 histiocytic or dendritic cell markers. And based on this, we can subclassify this immunophenotypic markers amongst the different subtypes of histiocytic dendritic cell neoplasms. Malignant histiocytosis can have overlapping phenotypic features with this more indolent group of histiocytic dendritic cell neoplasm, that is ECD, LCH, ICH, and Rosay-Dorfman disease. But the key thing that distinguishes malignant histiocytosis from this indolent group is morphology. It has a variable degree of nuclear pleomorphism. It can demonstrate a histologically aggressive behavior, oftentimes bringing up the differential of a poorly differentiated malignant neoplasm, in which case carcinoma, sarcoma, melanoma, even anaplastic lymphoma should be excluded, and appropriate phenotypic characterization should be performed before placing this in the category of malignant histiocytosis. My recommendation is that to consider doing next generation sequencing in these cases, especially malignant histiocytosis, for identifying therapeutic targets and a PDL1 stain upfront. So if you are not able to identify genetic targets, at least we can, if the PDL1 is positive, an immune checkpoint inhibitors could be attempted in that scenario. So with that, I'd like to take this opportunity to thank all my mentors at the Mayo Clinic, my colleagues and collaborators at the Mayo Clinic UAB, patients and families, Histiocytosis Organization, Histiocytosis Association, the Histiocyte Society, Adam-Chester Disease Global Alliance. These organizations have had incredible amount of support to patients and families and have abundant resources to support patients with histiocytosis, as well as provide educational resources for both patients and physicians. And to Mumbai Hematology Group, thank you once again, Dr. Agarwal and team, for this opportunity to present this webinar today. On this note, I also want to bring up, we have a Scientific Histiocyte Society annual meeting in Goa, India this year in November 6th to 9th. We hope to see many of you there, and we have a fantastic scientific agenda that has been planned by the Histiocyte Society. And there's going to be a brief introduction to Histiocytosis Association and Histiocyte Society, after which I'll be happy to take any questions. Thank you very much.
Thank you, Dr. Aishwarya Ravindran, for that wonderful lecture as always. Your last lecture was also superb, and this was also fantastic. Thank you so much for that wonderful lecture. And now I request our next speaker, just stay tuned with us. We'll have our question answer session afterwards. Let me share the screen again. So our second guest speaker is Ms. Dana Fournier. Ms. Dana Fournier is the Executive Director of the Histiocytosis Association, a global non-profit that is dedicated to addressing the unique needs of patients and families impacted by all histiocytic disorders. She is also a histiocytosis patient herself, having been diagnosed with LCH at the age of 6. In addition to providing educational and emotional support for families and patients and raising awareness around the world, the association funds several research projects each year. So I welcome Ms. Dana Fournier. Over to you.
Thank you so much. And thank you so much, Dr. Ravindran, for the amazing presentation and for explaining such a complicated group of conditions very simply. Appreciate it so much. I'm just going to share a presentation briefly with you. And thank you so much to the Mumbai Hematology Group for the opportunity to present. As was noted, we are a global nonprofit, so we do support patients and families around the world. And our vision is a world free of histiocytic disorders. So all of our programs are aimed to make that happen. So just to share a little bit of worldwide impact about the association, we have a physician directory that lists over 360 physicians from 59 countries. So if you are treating any patients with histiocytic disorder and have comfort in accepting other patients, we encourage you to sign up, and I'll share more about that. We also have an annual research program which just opened for applications and will close at the end of June. And that is to fund for researching histiocytic disorders. So I encourage you to look into that as well. We have a broad social media platform that tries to connect patients, families, and providers. And we have 11,000 subscribers on our YouTube channel and followers on social media platforms. We have supported over 19,000 patients and families from over 119 countries. And we also have virtual education opportunities that we host, oftentimes in partnerships with other advocacy groups from other countries and that support other conditions. So the association was founded in 1986 by Jeff and Sally Tohill, whose daughter was diagnosed with Langerhans cell histiocytosis. And for almost 40 years, we have also had a formal partnership with the Histiocyte Society, which you're going to hear from Kathy Wisniewski shortly about the society. They're a medical scientific organization focused on research and medical education for histiocytic disorders. Our annual research program has funded over 202 research grants since 1990, totaling over $7.5 million. And we also have a Histio Student Scholarship for students in the United States, which we hope to eventually expand to an international opportunity. And then in addition, we recently just started a travel scholarship opportunity through the Histiocyte Society for junior investigators who would like to attend the meeting. Our partnership with the Society has been to serve as secretariat and partner, and our goal is to alleviate the Society's leadership of the administrative responsibilities of running a volunteer-based organization. And so there's a variety of activities that we do in partnership with the Society, and we truly enjoy all, learning from them and all the amazing work that they do on behalf of the patients and families that they support. Our partnership is demonstrated each year through our research funding cycle, where the Society Scientific Committee conducts the review of applications for funding. And this is a vital part of our association's Board of Trustees selection process for which research projects we fund each year. In terms of our mission, as was mentioned, we have a variety of different aims. We provide support for the community. So we have virtual peer-to-peer connect groups. Currently, we offer them in English and Spanish, but very shortly, we will be expanding that to 28 different languages. And we hope to continue to increase that opportunity to bring families together. We also take inbound information from families and patients around the world. We have the opportunity to reach us by email, by phone, and by WhatsApp. And we'll help connect you with resources, providers, or for any providers, if you have questions, we can also help direct you to consultation with other experts. We do a tremendous amount of awareness and advocacy through events and different opportunities such as conferences. We have a lot of education that we host as well, webinars and regional meetings where we bring patients and families and providers together in person. And then, of course, the research that we fund as well, as I mentioned. I'll just leave this up on the screen just for a moment so you can see more of the opportunities to engage. We encourage you to visit us at histio.org, HISTIO.org, and explore all of the different resources and information that is there. We have resources for patients, for families, for medical professionals. So please take advantage of everything that we offer. It is free to use the resources that we have, and we just want to make sure that everyone has the information that they need. Database. You can visit us at histio.org and you can look for the physician directory, or the link is on the screen. Resource overview and find a doctor, and it's free to join the directory, and you can help patients and families find you wherever you are in the world. For patients and families that might be listening, you can also explore. This is a searchable map. You can put in your country, your state, your diagnosis, and you can look for providers in your area. Their contact information is listed there as well. We also have a physician resource center with brochures about histiocytic disorders offered in English and Spanish. We also offer care bags for newly diagnosed patients. Currently, we're mostly offering those within the United States. However, reach out if you are interested, because we have ways that we could create digital care bags as well. And there might be opportunities to expand in the future. We have a variety of different talks and webinars throughout the year. Some of those include continued medical education, which you can get credit for. So we encourage you to sign up for emails so you can learn more about those. And then we have a variety of patient-specific resources as well, which are all listed on this resource center. So if you want one quick link to access to navigate our website more simply, you can just visit that site. And lastly, I'll just mention that we are involved in a lot of international collaboration with patient advocacy groups around the world, formally coming together in a coalition called the Coalition for Histiocytosis International Patient Support. Some of the talks that will be happening over the next few months will be with the Erdheim-Chester Disease Global Alliance, who are formal partners of ours. And our mission is to just combine our efforts for the patient family community so that we have one united voice. So we just want you to know that you can lean on us as a resource, and that you can have families reach out to us as well as a resource. So from the bottom of our hearts, thank you. You make a difference, you're saving lives, and you're powering hope. So we appreciate everything that you're doing and hope to connect with you as well and to be a resource. Thank you for the opportunity.
Thank you, Ms. Diana, for that wonderful insight. And we now move for our third speaker. So we have with us our third speaker for the day, that is Ms. Kathy Wisniewski. Ms. Kathy has worked with the Histiocytosis Association and the Histocytic Society since 2008. During that period, she has held many roles in both organizations, but today her primary responsibilities lie in managing the Histiocytosis Association's research grant program, producing the association's podcast entitled Beyond the Diagnosis, and managing the Histocyte Society, a global group of over 200 physicians and scientists dedicated to researching histiocytosis, finding better treatments, and ultimately a cure. Well, thank you so much. Over to you, Ms. Kathy.
Great. Thank you so much. I echo everything Diana said as far as just really appreciating this opportunity. And I'm happy to be with you here today. Let me just share my screen. Okay. So as mentioned, the Histiocyte Society is a nonprofit organization. We currently have over 250 physicians. We've been growing quite a bit over the last couple of years, which is really exciting for us. And all of these physicians are from around the world, physicians and scientists, and we are committed to improving the lives of patients with histiocytic disorders through clinical and laboratory research. And it is a privilege and an honor for me to work with these doctors on a daily basis and to help promote the mission and the vision of the society. So the society started back in 1985. It was a historic international workshop that took place in Philadelphia. It was started by Dr. Giulio D'Angio, and that original meeting had only 15 attendees. Now today, as of March 23, we have 250 physicians and scientists again, and our meetings are also increasing. We now have attendance every year of over 200, which is very exciting as the energy just continues to grow and we keep moving forward in our mission and vision. So what is that mission and vision? The mission of the society is to advance knowledge about and improve outcomes for patients with histiocytic disorders through clinical and basic research and education. And we hope that will move us towards our vision to be the world leaders in understanding histiocytic disorders and improving the lives of patients and families who have these disorders. Obviously, ultimately, we want to be able to find a cure for each one of these disorders that's under the umbrella of histiocytosis. And this is a little bit of a map of where our members are located. And we are excited to have 3 members that are located in India. And we grow all the time with members from all over the world. So we're always excited when we get a new location to add to our membership. So the goals of the society are to improve the state of knowledge of the histiocytic disorders and improve the welfare of patients with these disorders, to promote, facilitate, and carry on research into the histiocytic disorders, to facilitate and provide a forum for healthcare professionals for effective communication concerning these aims. And we do that through our annual meeting and also through a listserv that we have where physicians can communicate about difficult cases and things like that and get advice from the other histiocytic disorders physicians around the world. We want to promote education and educate physicians, scientists, and others in matters related to the histiocytic disorders. We do that through webinars, again, through the annual meeting and other avenues. And we want to be able to advise lay organizations in educational and other matters. Just like Diana was saying, we work very closely with the association in order to be able to provide education and some collaboration in making sure that information is correct across all avenues. So it's a very close partnership that we're very proud of. So some of the accomplishments that we've had is we've worked on a common language of uniform disease classification. This is an initiative that we continue to work on. We want to standardize diagnostic criteria and develop guidelines for patient evaluation and follow-up. And earlier you heard that our annual meeting is going to be in Goa this year, which we were very excited about. We've never met in India before. And we also heard about the Education Day. And on this day, the aim for that day is to start to develop guidelines for lower and middle income countries and be able to use the methods and the treatments and the drugs that are available to them in order to provide guidelines on how to treat these diseases. So there's several ways that you can get involved. You can become a member. I've put up a QR code there that will take you directly to our website. And we've recently implemented a 50% discount for trainees off the membership price. We do have an upcoming webinar coming up on June 6th. It's going to be by Dr. Nirali Shah from the National Institutes of Health. And she will be talking about HLH-like toxicities following cellular therapy. We'll probably have at least 1 or 2 additional webinars coming up, which will also be shown on our website when they are planned. Again, we have the 40th annual meeting of the Histiocyte Society coming up, and that will be in person in Goa and also offered hybrid. So you will be able to attend virtually as well, if that's something that you're interested in. And then again, as mentioned, we have this special education day on November 6th, and that will be all day long. And we will talk about pathology, HLH, LCH, and rare disorders. So thank you very much for your time. Again, I appreciate being here, and I'm happy to answer any questions you may have.
Thank you, Ms. Kathy, for giving us light and insight on this. And now I request our discussants to please put the hand raise signs so that we can start our question answer sessions. So, Dr. Ankur, your question.
Good evening, sir. And good evening, Dr. Ashwar. It was actually very, very comprehensive, nice lecture. You have cleared up many doubts. Now, I had a similar case of a known case of a AML which came for a remission. It had a nodular collection of the histiocytes. Now, my questions are whether it's a reactive histiocytes or a malignant one, or and what is the root? Because often we get the bone marrow samples for the flow cytometry also. Does the flow cytometry have a role in these cases? And how do we approach in these type of scenarios?
Thank you for the question. So in terms of in a patient with AML, and when you see a nodular collection of histiocytes in a treated marrow, when you're doing a follow-up marrow, typically they're just benign histiocytes. They're part of the serous stromal atrophy, which is just a post-chemotherapy effect that we see in the bone marrow. Oftentimes they might be mixed with hemosiderin-laden macrophages, and there is some serous atrophy, meaning in the areas that appear like serous-like or gel-like. And there are a lot of histiocytes, lymphocytes, plasma cells that mix. Most of the time, they're just a spectrum of post-chemotherapy treatment effect. To answer, and also alongside, typically in AML, we don't see a transformation to malignant histiocytosis. This is like, the analogy I would want to give is, B lymphoblastic leukemia lymphoma transforming to aggressive large B-cell lymphoma. It's just not theoretically feasible or possible, or to our knowledge at this point in time, we have not seen a case, we have not heard of it. So the transformation of an acute myeloid to malignant histiocytosis would be really impossible to occur. So in that setting too, this is likely a reactive proliferation. Second thing about flow cytometry, in general, flow cytometry, in our lab, we cannot find out the histiocytes phenotype based on our flow cytometry, but there have been certain labs out there which had shown that they can diagnose Langerhans cell histiocytosis by flow cytometry. But typically these macrophages may not survive processing because they're kind of a large cell for them to go inside the cytometer. They might not completely survive processing. It's not the best tool to evaluate clinically, but in the research side, they have done flow cytometry to evaluate the various macrophage in terms of microenvironment in myeloid malignancies and also other solid tumors per se. But right now, clinically, not so feasible. And to the third question is that approach to this type of scenario, it's most oftentimes whenever you see histiocytes in a post-treated case, if it's an AML, sometimes you see that even in a DLBCL case, if it's there was a case I had DLBCL involving the spleen, and the patient was treated with R-CHOP, but then there was still a mass that was present. It was not PET avid. Splenectomy was done, and it was a histiocyte-rich pseudotumor and not malignant histiocytosis. These cases really have a very bland morphology. They do stain with histiocytic markers, but they are negative for cyclin D1 uniformly. Cyclin D1 is a really good surrogate marker for determining neoplastic histiocyte origin, provided the cyclin D1 is overexpressed in histiocytes and not your background cells, because it can also be positive in endothelial cells, fibroblasts, can also be positive in other solid tumor malignancies. Most commonly, I've seen it in melanoma, as well as undifferentiated pleomorphic sarcoma and so forth. But they have a very bland histology and nothing, not even close to this malignant histiocytosis or even other indolent histiocytic neoplasms per se. So in general, we have to, that's where the clinical correlation radiology comes a lot in play. Every time I diagnose a histiocytosis case, it's always a conversation with my clinical hematologist here. What do you think clinically and radiologically? Does it match? Even though there are straightforward diagnoses on path for Rosay-Dorfman disease, LCH, and malignant histiocytosis.
Thanks a lot. Thanks a lot.
Thank you, Dr. Ankur. Dr. Vidisha, your question, please.
Thank you, Dr. Aishwarya. So the same question, like in a bone marrow biopsy, we had a patient with fever, pancytopenia, and his bone marrow biopsy was showing us very innocuous looking histiocytes, but there were like sheets of them. So for me to differentiate from a benign, because it's a bone marrow where you normally see a histiocytic proliferation. So benign versus malignant, you suggest cyclin D1 would be, because in this patient, the CD68 was positive. CD163 was positive, S100 was negative, and CD1A was negative. So for me to call it as a malignant proliferation of histiocytes versus a benign, what markers further do you suggest? Or do you think NGS would be the answer to this?
No, not necessarily, because in patients with fever, pancytopenia, the bone marrow is probably not showing enough recovery by producing hematopoietic stem cells, and that's why what we are seeing is only just histiocytes. If you're very concerned about a malignant histiocytosis process, cyclin D1 could be done, but in general, morphologically, these look extremely bland. So when they are bland appearing, we know it's not malignant histiocytosis by morphology, so that's excluded by morphology. But your other indolent histiocytic neoplasm, like Rosay-Dorfman disease, will show positivity for S100 and OCT2. So that could be one of the markers if you're suspecting that by morphology. Second thing, LCH, you've ruled out by CD1A and Langerhans, so that's great. Or CD1A alone, it's fine too. The third thing would be Erdheim-Chester disease. Now, ECD is not a diagnosis we make by pathology alone. You will have the clinical phenotypes. The patient usually presents with long bone involvement or a retroperitoneal mass. There should be other clinical and radiological signs. Without that, presenting for the first time in the bone marrow is essentially unheard of. So in that case, the only question comes, is it ECD or not? It's probably not if you don't have other clinical radiological signs. So I wouldn't even go and work further for a histiocytic neoplasm in that scenario, because you have excluded malignant histiocytosis by morphology and other things are excluded by S100, and this cyclin D1 is not necessarily needed in that scenario as well, because this is essentially a morphologic clinical correlation. And most oftentimes they are reactive histiocytes. If you still have suspicion, yes, you can still go ahead and do cyclin D1 after doing S100, OCT2, and CD1A. Finish that and it's all negative, then you can go and do cyclin D1. And I want to mention that cyclin D1 can be variably positive in reactive histiocytes, some of them weak, some of them strong. Typically in neoplastic histiocytes, they show uniform pattern of expression, uniform strong nuclear positivity, weak to blush cytoplasmic positivity. So that is a pattern of expression and not necessarily a positive expression that distinguishes reactive from neoplastic. So that's why we need to take the context of our H&E morphology into scenario along with S100, OCT2, and CD1A, and then evaluate cyclin D1 in conjunction with that.
Okay. And another second question, you just mentioned that BPDCN is no longer, a different entity and would be put under the category of malignant histiocytosis?
No, not under malignant histiocytosis. It comes under the category of histiocytic dendritic cell neoplasms. So the WHO actually, World Health Organization, the 4th edition, has 10 different distinct histiocytic neoplasms under the category of histiocytic neoplasms classification. However, the WHO 5th edition, the recent edition that came out in 2022, classifies the plasmacytoid dendritic cell neoplasm under the category of histiocytic dendritic cell neoplasm. Malignant histiocytosis is essentially a separate category. Malignant histiocytosis is not a term that is used by WHO or any international consensus classification. It's a term exclusively used by Histiocyte Society classification. I personally prefer the Histiocyte Society classification to diagnose it as malignant histiocytosis and subtype it, because in my practice, I've seen cases, even I don't do that, there is often a confusion between soft tissue sarcoma and the patient gets misdirected to sarcoma oncologist rather than a clinical hematologist. So that is why I specifically put malignant histiocytosis, I subtype it, and I add a comment stating that in the WHO and ICC, this is classified by so-and-so category, but whereas in our Histiocyte Society classification, this comes under the umbrella term of malignant histiocytosis, and referral to hematology is required for further management.
Thank you so much.
Thank you, Dr. Vidisha. Dr. Akshay, your question, please.
Thank you, sir. Thank you, ma'am, for this wonderful and comprehensive webinar. So my question is regarding differential diagnosis of BPDCN. So how do you differentiate BPDCN with acute and undifferentiated leukemia? So we have a case where around 90% abnormal cells are there, which are positive for CD123, CD4, CD56. 34 is negative. All the lineage specific markers are negative. Apart from it, HLA-DR is positive and CD117 is positive. Patient is not having any skin lesion although. And how to proceed?
Yeah, it's like, the typical mnemonic for this cases are CD1, 1, 2, 3, 4, 5, 6, which is CD123, CD4, and CD56. But the WHO requires the criteria for BPDCN classification from AUL is that you need to have at least 2 or more PDC markers. There is a more specific marker called CD303, and also the other one is TCL1. So TCL1 is actually better on bone marrow decal specimens because it can highlight the cells much better than your other cytoplasmic membranous markers. TCL1 is more reliable, sensitive, and specific markers. So that would be the way to go, is to do more specific PDC markers to categorize under BPDCN category. Most oftentimes, if you have 1, 2, 3, 4, 5, 6, it's a BPDCN unless proven otherwise. But we just need a more specific marker to prove that.
Actually, the problem we had was that patient is not having any skin lesion. And secondly, the markers 303 and 304 are not readily available. Centers.
How about TCL1?
That also we are not having in flow cytometry
aspect. Okay. There are other markers. Well, the other thing comes, it's like to classify the AUL, even without skin lesions, I think if it fits the phenotype of BPDCN, it would be put into that category. CD117 is quite unusual, but it also depends upon the extent of positivity in the BPDCN positive cells. Is it CD117 diffuse or is only focal? Is there any correlation that you can see?
It was partial.
It was okay. And how about NGS findings? Now, then we have to figure out what the NGS findings are. If there is any AML defining mutations, and that would help us to sway one way or the other, because the CD117 is a more specific myeloid marker, but it also can be present in, other tumors as well. But how about myeloperoxidase? And we should also make sure that is negative as well. So yes, I think in general, in my practice, I would do more of specific PDC markers. That would be the definitive way to go. But if you're not, if you don't have that, then NGS would be another way to confirm that. And it can happen where you don't see skin lesions and it involves a bone marrow. That has happened. I've seen cases like that. So it has to be taken into consideration. If you're not able to distinguish after all of this, then I would be descriptive in the comment that, this looks like a BPDCN phenotype, but however, we are not able to do more specific PDC markers for definitive subcharacterization, and let the wait for the NGS to decide. And they discuss with the clinical hematology team too. So sometimes we cannot put it into one bucket category, but we have to acknowledge and accept it and add a comment and as to what we are thinking clinically.
Right. Also, how helpful morphology would have been in this case?
Not at all. If you differentiating acute undifferentiated leukemia from BPDCN, probably not, because there are some papers that talk about BPDCN have a chain of necklace type of pattern in the nucleus, where the next to the nucleus you see these vacuoles or forming a necklace, a chain of necklace. Or hand mirror morphology. Honestly, we don't see that in sometimes in real time practical cases. These are textbook like descriptions. If you see that, great, but they are not very pathognomic. The key phenotype, the key way to distinguish them is by immunophenotyping. They are not malignant histiocytosis, I can say that, because malignant histiocytosis will show variable degree of pleomorphism as opposed to BPDCN being more of a monomorphous type of a morphology or a blast-type morphology. So it's the key is only having an extensive immunophenotypic characterization and in conjunction with flow cytometry.
Okay, thank you so much. Thank you.
Thank you, Dr. Akshay. Dr. Pushpanjali, your question.
Thank you, ma'am, for your nice talk. Ma'am, my question is, often we found that on histopathology that these are showing us very varied appearance, which may resemble with carcinoma or sarcomas and others.
Yeah.
So either we put a primary panel to differentiate them, and followed by, if all are negative, then we should put the malignant histiocytosis markers, or we should add these markers also as a primary panel, so that we could get this clue at the first our screening process.
That's an excellent question. And so since I do only hematopathology, when it comes to me, I add it up front. But for majority of general pathologists and community practicing pathologists, common things are common. So yes, absolutely rule out carcinoma, sarcoma, melanoma, lymphoma with anaplastic morphology. And I also want to mention melanomas can be CD68 positive. CD68 is a very promiscuous stain. It can be positive in so many tumors and confuse us to lead towards or have an anchorage bias towards malignant histiocytosis. So it is necessary to do an extensive panel once you've done the basic panel for carcinoma, sarcoma, melanoma, and even lymphoma for that. For usually we start with a CD45, CD30 for anaplastic large cell lymphoma and so forth. When you come to a point where you're calling it polydifferentiated malignant neoplasm, that point I would stop and do histiocytic lineage, because we don't want to put something into a category of polydifferentiated malignant neoplasm without exploring the malignant histiocytosis lineage. And that is the key takeaway I want to really deliver to this talk, is that remember, these are tumors that can be hopefully treated, but at least being channeled through the appropriate hematologist and followed up. So it's necessary that we take this into differential and work it up once you've ruled out the more common entities. So yes, rule it out and then do a panel. And I would do at least 2 markers. CD68, it's not my favorite stain. I typically do CD68, still I do it because it's widely available, along with CD163 and PU.1 is my go-to stain. And then based on that, then you can categorize that, whether it's fits into malignant histiocytosis. If it doesn't, then you would end up calling it as polydifferentiated malignant neoplasm, not further classifiable.
Thank you, ma'am. Thank you so much.
Thank you, Dr. Pushpanjali. Dr. Chitra Madivali, ma'am, you please. Question, please.
Hi, Dr. Aishwarya. That was a very excellent and lucid talk. Thank you so much for it. My question is, you mentioned CD4 as one of the markers that you include in the panel. So would you be able to tell us about, the extent and intensity of staining that it should have in these malignant histiocytosis?
Absolutely. I think CD4 is unlike CD163, CD163 can be negative in dendritic lineage of histiocytosis, but CD4 is positive in across all histiocytic and dendritic cell neoplasms. In general, the CD4 intensity will be less than your background CD4 positive helper T cells, but also it can depend upon the antibody clone and the protocol you use to develop in the laboratory. But majority of the times in our labs, in our practice, we've seen the intensity to be slightly lower. It's cytoplasmic and membranous staining, the CD4, when it marks the macrophages. That is one thing. But CD4 alone, so it typically stains diffusely. So all of the cells will be positive, intensity is less, so that answers the question. But I would not do it in isolation. Like I always do it in, it's not my CD4 is not my go-to marker. I put it here because in general that is more accessible to everyone. But my go-to marker is 68, 163 and PU.1, because unlike CD68, 163, CD4, which shows the cytoplasmic and membranous staining, PU.1 crisply highlights the nucleus of this histiocytes. Of course, PU.1 can be positive in reactive histiocytes, malignant histiocytes, the background B cells, as well as neutrophils. But in cases where I'm concerned for a malignant histiocytosis, I evaluate the PU.1 in conjunction with my other histiocytic markers, including CD4. I do it on an on and off basis, but not my primary go-to stain.
Thank you. And one more question. What triggers this transdifferentiation?
So that's an excellent question. I think we are trying to still figure that out. But in general, the hypothesis that we have is that, so when you treat a lymphoma and there is a primary clone, right? So you treat a lymphoma, the primary clone goes, it's suppressed. I don't think it necessarily grows away. Now, once the primary clone is suppressed, I think there is a second hit. Most common in malignant histiocytosis, you see a second hit in the form of an acquired TP53 mutation or an acquired somatic mutation in the MAP kinase pathway or PI3AKT pathway. What triggers the second hit? I don't know. That's something that will be a breakthrough when we find this out, but we don't know. But there is certainly a second hit. There is a proposed theory that the treatments could trigger the second hit in some lymphomas because it usually arises in the post-treatment setting. So when the second hit occurs in conjunction in the post-treatment setting, analogous to therapy-related myeloid neoplasm, similar concept, and that second hit triggers this lineage switch or causes this clone to undergo lineage plasticity, where there results in a lineage switch to a histiocytic dendritic cell lineage. This is a proposed theory I have, but we don't have any tools to figure it out. But the basics is that secondary malignant histiocytosis clearly has some underlying genomic instability. So in future, we need to apply these tools to identify which lymphomas are capable of transdifferentiating to malignant histiocytosis. That would be a bigger question to answer in research studies in future. But the limitation of that is that we don't have enough cases, or are the cases getting underdiagnosed is a bigger question.
Thank you. Thank you so much.
Thank you, ma'am. There are some questions from the audience. Dr. Dinesh Sheth has asked a clinical question. A 22 years old male, BALL on BFM induction, develops papillary eruptions over face, hand, and back. The biopsy shows histocytic sarcoma, which is CD163 positive, 68 positive, CD4 positive, and BRAF mutation positive. Bone marrow is in remission, MRD is negative. How would you like to treat this patient?
Yeah. It's a valid question, but I cannot comment on treatment because I only do pathology. Although there are, we know what treatments are used, but I think it's better for me not to comment. However, we have an upcoming malignant histiocytosis clinical management talk on May 18th, hosted by Mumbai Hematology Group as well. So I would defer that question and ask in that webinar to Dr. Abekun, who will be who's a clinical hematologist, who will be giving that presentation.
That's great. There is another question from, yes. Dr. Pushpanjali has already asked you in the chat box, and you suggest I just want to read out what Dr. Pushpanjali has asked. The recent WHO classification currently recommend malignant histiocytosis as anaplastic large cell lymphoma. Shall we use malignant histiocytosis terminology now onwards or ALCL for such cases? And if so, what should be the IHC markers for differentiation from classical ALCL?
So when we call something anaplastic large cell lymphoma, it is a T cell lymphoma. It's an anaplastic large T cell lymphoma, which could be ALK positive or ALK negative. And anaplastic large cell lymphoma, it doesn't relate or come under anywhere close to malignant histiocytosis per se. ALCL, immunophenotypically, they are always diffuse CD30 positive, and they're negative for any and all of the histiocytic dendritic cell markers. And ALCL, if it's ALK positive, it will show ALK expression. If it's ALK negative, it will be ALK negative, but it has the other phenotypic correlates like CD30. And of course, we'll do a panel of T cell markers, including CD4. CD4 might be positive here, but 68, CD163, PU.1, all of them will be negative. So ALCL is a distinct T cell malignancy, so it should not create confusion with malignant histiocytosis. The other part of the question is that WHO classification does not recommend the term malignant histiocytosis. They just classify as either histiocytic sarcoma, interdigitating dendritic cell sarcoma, or Langerhans cell sarcoma. The malignant histiocytosis is a term exclusively proposed by the Histiocyte Society classification. And I personally, this is my preference. That's not something I recommend to others. It's up to each individual's discretion. I personally prefer the term malignant histiocytosis in my diagnostic line, and also subtype it per the WHO and ICC, and add a comment what the Histiocyte Society classification states and what the WHO and ICC states, and the future recommendations for the malignant histiocytosis cases. So that would be the way to go in terms of subtyping it per se, but ALCL should not have any relations with malignant histiocytosis. On the other hand, CD30 expression in malignant histiocytosis, we did not explore it. So I don't know if CD30 will be positive or negative at this point in time. But regardless of CD30 expression, I believe that malignant histiocytosis needs to be proven by the IHC phenotyping for histiocytic and dendritic cell lineage.
Thank you so much. Another question from Dr. Miyat Maleswe. Can empiriopolysis be seen in bone marrow of HIV infected patient?
I want to bring up the point of hemophagocytosis and emperipolysis. Hemophagocytosis is when a macrophage chews up a cell and destroys it. That's what you see more common in HIV bone marrow, because that's HLH, hemophagocytic lymphohistiocytosis, can be most commonly associated in the setting of HIV infection, EBV infection, CMV, as well as malignancies. Now, emperipolysis, on the other hand, is when a cell is passing through the macrophage. In Rosé-Dorfman disease, the RDD cells, the lymphocytes, plasma cells are just passing through it. There is no destruction of the cells. So that is a phenomenon we reserve as emperipolysis. So in terms of bone marrow of HIV male, I would want caution that it's likely hemophagocytosis and not use the term emperipolysis. And certainly when there is hemophagocytosis, whether it is HLH or not, that requires the clinical and laboratory criteria to be 5 out of 8 criteria as per what we know now to correlate if it fits the picture of hemophagocytic lymphohistiocytosis. And yes, in HIV patients, you can see hemophagocytosis, but the presence of hemophagocytosis doesn't mean it's HLH. HLH is a complete clinical diagnostic criteria. We don't do it in pathology. But when I see hemophagocytosis in HIV patients, I put a comment and I say, please correlate with clinical and laboratory criteria to evaluate for HLH in the setting of known HIV infection.
Thank you so much, ma'am. Another question from Dr. Meenakshi Suri. Does IHC help to differentiate between reactive histiocytosis versus malignant histiocytosis post chemotherapy?
Yeah, I think we discussed this earlier too. I think I wouldn't really go into immunohistochemistry in terms of distinguishing that, because when you have a patient with a treated bone marrow, typically AML or lymphoma or other malignancies, they're mostly the reactive regenerative marrow always has histiocytes. Typically, they are mixed with fibroblasts, lymphocytes, plasma cells, and hemosiderin-laden macrophages. They really are very bland. So when they're bland appearing, you essentially rule out malignant histiocytosis because they by morphology, it's not malignant. If you still have suspicion for whether if it's reactive or the other indolent category of histiocytic neoplasms, you can absolutely do S100, S100 and OCT2. They should be negative in your reactive histiocytes. S100 can mark dendritic cells, the reactive dendritic cells. So that is usually very singly scattered. That doesn't imply by itself it's a malignancy. You need to correlate with OCT2 and CD1A. If you think there is Langerhans cell morphology, you can do a CD1A stain. But again, CD1A can be scattered, singly distributed. They usually, they don't form clusters. So that's just the clusters and being singly distributed distinguishes reactive from malignant. But cyclin D1, in my opinion, is really helpful, but it doesn't necessarily need to be done in all cases. But if you are concerned, my panel is S100, OCT2, cyclin D1, CD1A.
Perfect. And just to elaborate this, does also NGS help in such cases?
I wouldn't no, actually, because when you're dealing with in those post-treatment chemotherapy manner, they're very bland histiocytes. So when I don't have IHC signal I wouldn't pursue NGS because it's an added layer of financial burden for the patient. So, and also in bone marrows on core biopsies is often decalcification. So NGS is not recommended on bone marrow core biopsies. When you have clot section, it's great. But in my institution, we don't do clot section for bone marrows per se. It gets upfront collected as a fresh bone marrow aspirate for NGS when there's a clinical suspicion for myeloid neoplasm, AML, and so forth. So NGS will not help, and it's not needed when there is no IHC signal, and it should not be done on decalcified bone marrow. But if there is a clinical suspicion of histiocytosis and the patient goes for a bone marrow biopsy, then I would upfront get the bone marrow fresh aspirate and send it for NGS right up front. And that would help. But it would be very unusual for malignant histiocytosis to primarily present in the bone marrow as opposed to the other organs of involvement.
Thank you. And also, Dr. Savitri Singh has asked how many cases you see encountered this transdifferentiation taking place?
Well, in our research experience, I've seen about 8 of the 22 cases had transdifferentiation. In my practice here, in the past 1 year, I've seen 3 malignant cases, 3 malignant histiocytosis, and 1 out of the 3 was transdifferentiation. Honestly, the true incidence is largely unknown for histiocytic neoplasms, except for LCH, which is 1 to 2 per million. We don't know the true incidence of ECD, Rosé-Dorfman disease, or malignant histiocytosis. It's tough to answer the exact incidence rate for transdifferentiation because the true incidence of overall malignant histiocytosis itself is largely unknown.
Thank you. And if the patient has got your clinical criteria and lab criteria, this question is from Dr. Ankur, which is borderline for HLH. How many percentage, is there any percentage cutoff to see this hemophagocytosis on the bone marrow, or 1 or 2 is okay fine?
So, typically they say on bone marrow aspirate, you need to have more than 1 foci, at least 2 foci of hemophagocytosis. Your bone marrow aspirates are your best way to evaluate for hemophagocytosis because in the bone marrow core biopsy, what happens is that there could be admixed stromal macrophages, normal stromal macrophages of the bone marrow microenvironment in the background, which can create confusion with hemophagocytosis. So I would more than 1 foci on a bone marrow aspirate if I see like 2 different distinct foci of where a macrophage is clearly engulfing nucleated cells, not just red blood cells. It has to be nucleated erythroids and nucleated white blood cells and so forth. That's when I call hemophagocytosis, and I need to be able to see it on the aspirate. If sometimes aspirates say it's hemodilute and it's not very optimal for examination, then the bone marrow core biopsy, I tend to do CD163 if I can see prominent areas where I see engulfment of this nucleated reds as well as white blood cells in the bone marrow, then I would add a comment that hemophagocytosis is present.
And any marker, like for example, soluble CD25, which can definitely say that yes, it is HLH?
No, we can because no, we cannot. It's a morphologic and immunophenotypic correlation because CD163 will mark your, or CD68, any histiocytic marker will mark your reactive as well as hemophagocytic macrophages. So there is no specific marker where we can use for diagnosing hemophagocytosis. It's a completely a morphologic impression. Which needs to be correlated with aspirate. I prefer the aspirate over the core biopsy, but in the core biopsy, if I'm not able to pick it up by morphology alone, then I will go to an extracept of CD163, especially if the patient is pancytopenic and has a history of HIV or immunosuppressed.
Thank you. And out of your 22 cases of malignant histiocytosis, how many pediatric patients were there?
None, actually. The 22 cases were primarily based on I trained at Mayo Clinic, so this was done back when I was in residency. It took over 3 to 4 years to complete the study. So we are largely adult focused back in Mayo Clinic, and even now at University of Alabama, Birmingham, my practice is primarily adult focused. But I do get pediatric consults once in a while, and I've seen only 1 pediatric case of malignant histiocytosis, and that is the T lymphoblastic leukemia that transdifferentiated to histiocytic sarcoma, the case number 2 that I showed. I do get consults on and off, but my focus is primarily adult hematopathology.
Thank you. Dr. Gopinathan.
Good evening, ma'am. Thanks for the excellent talk. Actually, it was so clear, crystal clear. Right now, this is not a straightforward case of malignant histiocytosis, but kind of a slight tricky case. It's a young patient. He's a sailor by occupation. He was treated elsewhere in Japan. The clinical details at that point of time said he had fever, loose stools, hepatosplenomegaly, and he had hyperfertinemia and triglycerides. So they have done a marrow that they have given the report as HLH, and then partially the HLH has been treated, and the patient returned back to India in 2 weeks' time. Now, when he came back to me, he had just low-grade fever spikes for 1 to 2 days. But we had a suspicion whether it was just only pure infection or any other underlying malignancy that is masquerading as HLH. So we did a PET CT also. That was showing quite lighting up. The nodes are quite lighting up like a lymphoma. The uptake of nodes are quite high. So we did this time to for confirmation, we did a lymph node biopsy as well as bone marrow aspiration. Bone marrow aspiration is showing hemophagocytosis. There are some erythroid and phagocytosing, and that is there. But in the lymph node biopsy, we were just seeing foamy histiocytes. And on the PET, we also got a comment saying that there is some sclerosis at the diaphyseal ends of both the femurs.
Okay.
So can we have a disparity like this, HLH on the aspirate, but something like an earthen chester, like a foamy histiocyte on the lymph node biopsy? Can we have this disparity, ma'am?
So my primary concern is, was it HLH clinically?
Yeah, the original parameters that it has, what was reported in Japan was showing hyperfertinemia and hypertriglyceridemia. But when the patient returned here, his parameters were normal, almost normal. Ferritin is just at 863, which is quite low for the amount of HLH that we see. Triglycerides are near normal, ma'am. It is not a clear HLH right now, but this lymphadenopathy is persisting.
Okay, because in general, for HLH, even when there is hyperferritemia, hypertriglyceridemia, it still has to meet the other criteria. There has to be, it's very strict, and we have to exclude other reactive infection, inflammation, autoimmune conditions, which can just isolate it present as hyperferritemia or hypertriglyceridemia per se. So first of all, we have to make sure at the index point, if it truly met the clinical criteria for HLH, which means 5 out of the 8 criteria. The second thing is like, can hemophagocytosis be present ECD? We haven't seen ECD presenting acutely because this is more like an acute presentation. The most common times when hemophagocytosis is present in relation to a malignancy, the malignancy is typically, if it's lymphoma suspicion, and more oftentimes the T-cell lymphoma. Hepatosplenic T-cell lymphomas can do that. Peripheral T-cell lymphomas can do that. So that should be your first priority to exclude that. The foamy histiocytes in terms of diaphyseal regions and so forth, ECD, yes, it can affect the bony regions, but if a full PET CT doesn't show any other location and it shows only lymphadenopathy, it would be extremely unusual for ECD to present in with nodal sites of involvement. ECD is not a diagnosis of the lymph nodes per se, as opposed to Langerhans cell histiocytosis and Rosé-Dorfman disease, which can present in the lymph nodes. ECD is extremely unusual to present in the lymph node sites. And the third thing is like when you see foamy histiocytes and lymph nodes too, the main question is just like reactive sinus histiocytes. Abundant in reactive lymph nodes, which can also light up when you have florid follicular hyperplasia or florid lymphoid hyperplasia, you can have this extremely, enlarged germinal centers. They're reacting to something, and maybe it could be an infection, which is resulting in this HLH type of picture. And oftentimes you have the sinuses expanded by just reactive sinus histiocytes, and it should not be confused with sinus histiocytosis. If all of this is like ruled out and you still have a clinical suspicion for histiocytic neoplasm based on what you said, then the best thing is to evaluate by the markers. My suggestion is S1 under DOC2 and cyclin D1. If the cyclin D1 has this diffuse positivity along with the other clues of histiocytic and dendritic cell, suspicion based on the immunophenotypic spectrum, we can do NGS on the tissue to further evaluate.
Clinically, this patient has just got only the sclerotic changes in both the femurs, and in orbital apex, the radiologist is telling that is a soft tissue thickening. For ECD, the points in favor are only these 2 areas. Other than that, the
Okay.
pericardium, the kidneys, these are all not involved, ma'am, actually. So I think
Okay,
maybe
because
when
the
all the set
nodal
of
involvement
markers.
is nodal involvement would be quite unusual, but still,
Correct.
there are a lot of other mimics of ECD too. Sclerotic bone lesions could be just present in other benign mimics of bone lesions. And especially when you say sclerotic bone lesions, it's the knee bones that is most commonly involved in ECD. That is lower ends of the femur and upper ends of tibia, and it has a bilateral symmetric distribution, not unilateral distribution. So that is also a radiology is very key to bring up the differentials in this case, and after which we can evaluate further to see if it really is histiocytic neoplasm or there could be a lot of mimics. Mimics are way more common than it being ECD. And especially with nodal involvement in HLH, there is something else that is going on. And I think they really need to evaluate for T-cell lymphomas with the clinical history of hepatosplenomegaly and lymphadenopathy.
Thank you.
Thank you, Dr. Gopinath. Dr. Minu Angi, ma'am, your question.
Hello, and Dr. Aishwarya, very informative talk, and thank you for the talk. My question is NGS required in all cases? And if yes, which panel you are using, which gene panel?
So it's a great question. So in my practice, for all histiocytic neoplasms, ECD, Rosay-Dorfman disease, LCH, malignant histiocytosis, even xanthogranuloma family of lesions such as juvenile xanthogranuloma, we go ahead and do a comprehensive NGS. There is no single panel that can be done across all institutions because NGS can be very variable depending upon the number of genes utilized in a panel. But what I use in the NGS panel, I want to make sure there is MAP kinase pathway mutations be present. In general, the KRAS, NRAS, MAP2K1, BRAF E600E, and also PI3AKT pathway mutations such as PTEN. So these are the mutations that has to be present in the panel for me to add an NGS panel for mutations. But even with the panel that we have that covers 500 genes, we still struggle to find genetic mutations in some cases of histiocytic dendritic cell neoplasms. It's possible that we always use targeted NGS. So the go-to way would be whole exome sequencing, but it could be really very tedious to do in every case at this point in time. So there is no good answer for that, what panel should be used, but I would make sure the panel includes MAP kinase pathway mutation at the very minimum to evaluate for histiocytic neoplasms, because in 80% of the cases, of 70 to 80% of the cases, they usually harbor MAP kinase pathway mutations. In 10 to 30% of the cases, they could harbor PI3AKT pathway mutations, and sometimes in a proportion of cases, approximately 10 to 15% in my practice, we don't find any mutations at all. But we still try to do as much as we can for the patient care.
Okay, thank you.
Thank you. Dr. Ramesh, your question, please.
Good evening, ma'am. That was a wonderful talk. So I have a couple of questions. My first question is, what is the incidence of extranodal presentation in malignant histiocytosis? Because in the case series which you showed, there are many cases which were involving the ovary. So what exactly is the incidence of extranodal presentation in malignant histiocytosis?
So it's very variable. Like I said, we don't know the true incidence of malignant histiocytosis itself. So it's very hard for me to comment like what exact proportion might present in nodal versus extranodal sites. All I can say is malignant histiocytosis can present anywhere, in any location. It could be nodal sites, it could be extranodal sites. Extranodal sites I've seen would include even brain lesions, GYN organs, gynecologic tract organs, liver, lung. It can present essentially anywhere. So it's hard to say, but in our cohort, I think it was an equal mix of both nodal and extranodal phenotypes per se. So it's very variable from patient to patient.
My second doubt is, we showed that 60% of the patients had CHIP mutations, epigenetic alterations in there. We know that CHIP mutations, they tend to CHIP mutations found in like MDS and MDS patients also.
Yeah.
So the MDS AML patients also tend to have CHIP mutations at many of the times. So my doubt is like why AML does not have transdifferentiation into malignant histiocytosis.
Yeah, because the way I see CHIP in general, we think histiocytic dendritic cell neoplasm with the literature that has come out in LCH most abundantly, we tend to put this under the myeloid neoplasm category. So if you see the WHO 5th edition, they've actually put the subsection of histiocytic dendritic cell neoplasm under the myeloid category, whereas the WHO revised 4th edition was including the histiocytic dendritic cell neoplasm under the lymphoid category. So much is known right now, so we classify this under the myeloid category. So when you have the myeloid under the myeloid category, we have known and we have established that the histiocytic neoplasm can be associated with myeloid malignancies. Association doesn't mean transformation or causation. So this is a known occurrence. We've seen in ECD, depending upon the study or the group that you read, it varies anywhere between 3% to 10% being associated with myeloid malignancies, most commonly being CMML, CML, and so forth. So in AML, so I feel in AML, the way we kind of objectively think it's an association, it can be an association. I'm yet to see a case where there is AML and a malignant histiocytosis. I've seen cases of AML with LCH. That can happen, but AML with malignant histiocytosis get to see. But even if they occur concurrently, they are not essentially transforming from one to the other, because a immature cell cannot transform to a mature cell. It's like lymphomas again, a low-grade lymphoma such as CLL, SLL transforms to aggressive large B-cell lymphoma. We have yet to hear of, at least to my knowledge, I've not heard of B lymphoblastic leukemia lymphoma transforming to diffuse large B-cell lymphoma. It's just not theoretically possible, or I've not seen, to my knowledge, at this stage. In medicine is ever evolving. You might perhaps know about these cases in future. So the same concept applies in acute leukemias too. Acute leukemia is an immature myeloblast or immature monoblast. So it's just not possible for us to transform to a more mature phenotype. It can occur concurrently, sure. I think there have been rare reports that state that. But again, the most important thing to think about in a case with acute myeloid leukemia is it myeloid sarcoma and not malignant histiocytosis. Oftentimes, I've seen cases that get misdiagnosed as malignant histiocytosis, when in reality, they are just extramedullary involvement by myeloid sarcoma. And myeloid sarcoma has a very monomorphous morphology on H&E stain sections, as opposed to malignant histiocytosis having a variable degree of pleomorphism. As I show in this case, myeloid sarcomas typically tend to be cyclin D1 negative. If it's a granulocytic lineage, you can do CD34, CD117, and it's easy to figure out. But if it's a myeloid sarcoma with a monocytic differentiation, that's where the confusion comes with malignant histiocytosis, because there is no good marker to differentiate myeloid sarcoma with monocytic differentiation as opposed to malignant histiocytosis. Both of them will show CD68 positivity. Both of them will show CD163 positivity. But I believe that cyclin D1 is usually negative in myeloid sarcoma cases, and the morphology is more monomorphous, as opposed to malignant histiocytosis being uniformly cyclin D1 positive, and morphology is like polydifferentiated, overtly malignantly appearing cells, like the plump fat cells. That's the key difference between both of them. So we have to keep in mind, in a case with AML, before calling anything malignant histiocytosis, we have to ask ourselves, is it myeloid sarcoma?
Thank you. Thank you, Dr. Ramesh. Last two questions from the audience. Dr. Rahul Nima wants to know, what is the latest criteria to diagnose malignant histiocytosis in dry scanty tap?
In a what? Sorry?
In a dry tap.
In a dry tap. Oh, in bone marrows. So, I've only seen malignant histiocytosis in the bone marrow when there is already an extranodal sites of involvement. So we cannot diagnose on an aspirate. Malignant histiocytosis is something, it's a morphologic H&E based description or H&E based suspicion that will lead us to work up for a polydifferentiated neoplasm. So you will see it on the bone marrow core biopsy. If even dry tap, then we just call it hemodilute specimen non-diagnostic. Then we have to review the bone marrow core biopsy, and if you have involvement by this pleomorphic appearing cells, just like the case number 2 I showed in the patient with T lymphoblastic leukemia that transdifferentiated into histiocytic sarcoma, you can see this malignant cluster of histiocytes in the bone marrow effacing the bone marrow architecture, causing pancytopenia, and we can apply immunohistochemistry in that setting. The same panel of immunohistostains that I showed, 68, 163, PU.1, along along with genetic and Langerhans cell markers can be applied to phenotype it. Unfortunately, at that point in time, we cannot do NGS, and that is something we just have to treat it with, general, usually they do ice chemotherapy and so forth. We can do PD-L1, however. PD-L1, in my opinion, it really helps. Even in a bone marrow decalcified specimen, we can assess for PD-L1 expression in the tumor cells. So the patient might be a candidate for immune checkpoint inhibitor therapy. If NGS is not, if the bone marrow's only site of involvement would be extremely unusual, there'll always be an extramedullary site of involvement. For NGS purposes, I will recommend biopsy of an extramedullary site, which can be prioritized to do NGS to identify therapeutic targets.
Thank you. And then the last question from Dr. S.K. Sharma, can you please elaborate on this emperipolysis? Is it just an engulfment of cells by macrophages, or just
Yeah.
an entry of one cell into another, as seen in some
Yeah.
autoimmune conditions or hepatitis, where lymphocytes enter the ordinary hepatocytes and not the Kupffer cells?
In general, the emperipolysis, you can call emperipolysis when a cell is passing through another cell. That's the phenomenon of emperipolysis. The reason we stress on macrophages here is that because we're discussing this phenomenon in the setting of histiocytic neoplasms. Emperipolysis just means one cell passing through another cell. It can be any cell, doesn't necessarily need to be macrophages. But most commonly observed phenomenon in day-to-day practice is that in Rosé-Dorfman disease, I see this as a most common finding where the Rosé-Dorfman cells really tends to have this kind of phenomenon called, it engulfs the inflammatory cells, which is lymphocytes, plasma cells, neutrophils, sometimes eosinophils too. These are just passing through the Rosé-Dorfman cells. Rosé-Dorfman cells don't destroy this. Emperipolysis by itself is not pathognomic for a histiocytic neoplasm or any other malignancy. Emperipolysis is just a tissue microscopic based description of what happens at the tissue level. While emperipolysis in the setting of macrophages is more common in Rosé-Dorfman disease, as well as malignant histiocytosis with Rosé-Dorfman disease-like phenotype, it can totally be seen in reactive histiocytic proliferation. You biopsy a lymph node, you can see emperipolysis in the sinus histiocytes. That doesn't mean it is malignant histiocyte, or that doesn't mean it's a histiocytic neoplasm. You can see that in hepatocytes, sure, definitely. Sometimes you see that in megakaryocytes in the bone marrow. Oftentimes you see an aspirate, take a megakaryocyte, you'll see a neutrophil or a nucleated erythroids inside the megakaryocytes. They're not destroying it. The destruction thing happens when it's a macrophage. That's when it's called as hemophagocytosis. So hemophagocytosis is typically a macrophage that is destroying your nucleated reds, nucleated whites, and so forth. That's the key difference. Hemophagocytosis is exclusively to macrophages. Emperipolysis could be any cells. It's really harmless, but it's just a morphologic description frequently observed in Rosé-Dorfman disease and malignant histiocytosis, but I would never equate that as pathognomic for a histiocytic neoplasm.
Thank you. So now there are no more questions from the audience. I must say you are fantastic and superb. Every point was so crystal clear, and you solved all our doubts so patiently. Each and every point was really wonderful. Thank you so much for being with us today, and thank you for this wonderful question association. And I now hand over to Intas for the final vote of thanks.
So thank you, sir, for the opportunity. And we are now towards concluding this wonderful webinar. I must say this was an exciting and enriching overall time, which we has enabled everyone to gain from the wisdom and expertise of the speakers. I, Suresh Tiwari from Intas, take this opportunity to thank you, Professor Ambi Agarwal, sir, Dr. Amit Khurana, sir, and all the discussants and delegates who have taken time out of their busy schedule for this program. Thank you so much for joining us today. Have a wonderful weekend. Thank you.
Thank you.
Thank you very much. Thank you, Dr. Agarwal. Thank you, Dr. Amit. Thank you, everyone.
Thank you.